start by saying that, exactly as Barack just pointed out, whilst we're saying catheter passports in the community setting, one thing you will realise, and one thing that I must say right from the word go, is that the successes that we did eventually see in Kent were not just because of the catheter passport in the community setting. It was the fact that we implemented the passports throughout the whole of Kent from every health and social care sector. But we started off in the community setting. So in Kent Community Health NHS Foundation Trust in 2012 became one trust that was a legacy organisations of West Kent and East Kent. We serve over 600,000 people in East Sussex and London. I know it's confusing, so we're called Kent Community Health. We have thought about changing the name, but we decided to stay the same. 1.4 million people in Kent. We have over 5,000 staff. We've got doctors, community nurses, physiotherapists, dietitians, health visitors, school nurses, to name but a few. We provide care anywhere, pretty much, in the community setting, and I think any of you that work in the community setting understand that. Our lovely health buses, we have a dental bus that is driven by a dentist who is dual qualified, and he literally will drive to a site, do his surgery and drive away again. But the buses seem to be the way forward. I don't know how many of you also work on buses, but from an infection control perspective, that can be quite challenging, and it comes with its own unique issues. However, it seems to work. We reach the population, we get to the people that we need to, and we do what we need. So, background of a catheter passport. Setting this into context of the day-to-day, really, although I'm talking about a catheter passport, as both Linda said this morning and Sarah said this morning, nothing can happen in isolation. And what had to happen was something that we had to make a key issue very central to us as an organisation and find what we could do to try and improve. So in 2012, we were, because of the two legacy organisations, we were not in a fantastic place. We had absolutely no robust surveillance at all. We couldn't tell you what our CAUTI and UTI data was. Something I think we may all suffer from is actually we didn't have a definition of CAUTI or a UTI. And as been mentioned today, there isn't a national definition. So where do you begin? And how do we all start comparing ourselves to each other if we haven't got that measure to start off with? I think we all suffer from this, no matter where we work. Poor communication, poor healthcare records, health workers not talking to each other, someone discharged from the acute sector to the community with not all the information that they need, someone discharged from the community sent back to the acute sector with not all the information they need. We refer someone to the GP, we forget to tell them something, they refer someone back, they forget to tell us. No matter where we go, I think central to most things that we find within failure around the NHS and healthcare is communication. And like everybody else, we were absolutely no different. And I'd just like to say, whilst it has improved, we still haven't found the cure for that yet. We didn't have auditable data about daily catheter care. And again, that was partly because there were two different legacy organisations, some of which had implemented Saving Lives audits, some have implemented Essential Steps audits, but no one was centrally collating all of that data together to even give us a baseline. And then whilst we had information for our patients, and actually we're very lucky in Kent Community Health that we do actually have a continence team, we did have information for our patients, but there wasn't a consistency of information that we were providing to our patients. So overall, it was really hard because we didn't know where we were coming from. We knew what we wanted to get to, and that was just better. Initially, it was about empowering our patients, really, to allow them to have better self-care, as well as us as health and social care workers to be able to help improve their journey. So we started off by setting up a CAUTI and UTI reduction group. And I'll say at this stage, it was just our organisation that formed this group. we decided that we had to have a single definition of acquired UTI and CAUTI, and we agreed that. Now, I need to state at this point, again, those of you that work in the community will understand, as we provide care throughout a whole community, it's very hard to measure our patients that are actually in the community in their own homes. So this data is based on our community hospitals where we are able to measure our data. And there were 12 hospitals in Kent that we were able to measure that against. We implemented central monthly surveillance, and it was true surveillance. It was every month we looked at every single patient on every single ward and whether they had had a catheter-associated urinary tract infection acquired in that unit at any time during that month. And every month that was reported and continues to be reported to this day. Those reports then started going through the central governance committees, and people started comparing themselves to each other. And we were able to see there was actually quite a huge disparity across the county. Like I said, from the two previous legacy organisations coming together, clearly different practices had different effects. One of the key things was that the catheter policy was revised. And within the catheter policy, they then implemented the catheter passport. The catheter passport itself was something that we thought was really important, and we designed and implemented that really simply. Obviously not. I would just like to say thank you to Yorkshire Continence and Infection Prevention Control Team, because I have to say it was their catheter passport that originally gave us the idea. So back in 2011, someone had gone to a conference and seen them present their passport. Took it back to our organisation and then held, most importantly, patient representative workshops. We had an awful lot of our long-term catheterised patients come in and talk about their experiences. And again, I'm sure as our patient rep, had you been able to come this morning, would tell you, again, poor communication between healthcare workers, different people changing their catheter. A lot of people didn't know why they had their catheter inserted. It was inserted in an acute trust. The first time it went wrong or needed changing, they went to their GP. After they went to their GP, a community nurse changed it. After that, they went to a nursing home and one of those nurses changed it. And nobody had all the records to know what the initial catheterization reason was. There was no challenge about, did this person still need a catheter? There was no challenge about any of the practices involved, and there was no continuum. And I know someone had asked this morning about, what do you do when you routinely change catheters if someone has an infection? And again, no one knew, really, and there was no information for the patients or the healthcare staff to actually base everything upon. So we decided to try and put all of this into a catheter passport alongside the policy that we had. And in the passport, we decided 3 main areas. So it was the healthcare intervention section, and most importantly in that was why was someone catheterised, and a review of the need at every single change. And that has to be documented within the catheter. The patients themselves, not surprisingly, they wanted contact details of a healthcare worker. So who, if their catheter became blocked, who did they contact? And again, because it's that patient's passport, we write whoever that key person is, and it could be their district nurse, it could be their GP, it could be the urologist at the hospital, depending on them. And that's why it was so key to them, because it was theirs and it was personalised. And very, very central to everything was patient advice and self-care. I don't know how many of you have seen, there's an episode of The Royal Family about the grandma with her catheter, emptying the catheter in the sink whilst making a cup of tea next to it, using the same spoon to stir everything down. Again, those of you that work in the community know that actually this is reality of some of the homes that we go into. Most catheterised patients in the community, either themselves or their carers or loved ones, are caring for their catheter for them. And a lot of people, I live in Thanet, we've got high levels of poverty in Thanet, and whilst people try their best, sometimes their best is not that hygienic. So it's very, very important for us to make sure we had that information in there for the patients and carers themselves to know what they should be doing to look after it. So we designed the passport and we shared it around. We were very lucky that we actually then applied for some funding from the NHS Innovation Fund. Thank you very much. And then we had a big launch at a conference in 2012, in the October. Now, I'm hoping you can all see this. This actually is pages from the Catheter passport. So as you can see over on the left-hand side there, it's the patient details themselves. And like I said, very central to this is the passports are theirs. They are not ours. And the key thing is it will never replace our own documentation, and that has caused some problems because people are double documenting. But this is to allow the patients to have that information. Is their details, and like I said, with the healthcare professional detailed, it is tailored to that person and whoever is their key person. And within Kent, we've agreed, usually it is their community nurse, but on some occasions, like I said, it is a urologist. It may even be actually their best friend's neighbour over the road who is a healthcare worker. We tailor it to what they need. Information on the other side is about why they were catheterised. Do they still need it? What was the date they were first catheterised? All the size and the normal information that we need to have. Very importantly, it says at the bottom here, details of how you get your catheter equipment. We had an awful lot of issues of patients not being able to access their catheters, not getting catheter equipment, so there were delays in changes of the catheters as well, which brought its own issues with it. Where it says here the catheterisation change, although on here, on this slide, there's only one page, there's actually 20 pages within the passport. So this can last someone a very long time. And every time it is asking, why are you recatheterising? Have there been any problems? And what is the date of the next planned change? And that is really central to everyone every one of our patients and our staff. Because again, very rarely does the same person go out twice and catheterise a patient. It's usually done by very different people. Information, as we said, for the patients themselves about how they look after their catheter. So we launched at a conference, like I said, in 2012. And from then, through that winter and through the next spring, we went out throughout our organisation, predominantly focusing on our community hospitals, but our community nursing teams as well. We had at that point made contact with local acute trusts in Kent. There are a number of acute trusts and a number of different CCGs, all of whom supported us in doing this, but at that point they had not implemented at the same time. I'm sure, like many of your organisations, we have a fantastic infection prevention control link worker network, and we use that network to train our link workers so that they could also then go out and give further information. We're also very lucky in Kent that we actually have a care home support team. So we actually have a team that are going into our nursing homes, our residential homes, NHS and private, and supporting the teams there. So we were able to get the catheter passports where we needed them in the community nursing homes as well. In a minute, I'm going to show you a slide to show that in the first couple of years, we actually got a fantastic reduction. And then, as people have been saying throughout the day, you kind of take your eye off the ball for a bit, and we plateaued. Now, in August 2014, Kent and Medway set up a joint HCAI reduction group, and we set up a work plan, and one of the focuses was around reduction of CAUTIs across the whole economy. And it was the first time, I think, we had already just sat down and said, right, let's scrap boundaries, let's ignore your patients, my patients, let's look at our population. And we all agreed that we would revise the passport and everybody would use it. And we did that. It wasn't as easy as it sounds because lots of organisations, as we all know, there's a bit of bureaucracy, there's a bit of politics. But in the end, we all agreed to do it. We had GPs sitting on the panel reviewing. There was, like I said, representation from social care, paramedics, everything that you can think of in health and social care, all reviewed and agreed one passport. And in summer 2015, it was implemented across the whole health economy, alongside another launch that was in the public community magazines. Medway Community put it into their magazines, and there was a big drive to push it through. Now, as you can see up here, at the start of it, we had quite high rates. We started measuring, and we got a bit of a peak initially. I still think that initial peak of data was actually about improved reporting, because, like I said, prior to that point, we did not have robust data. But as I was saying earlier, I think this is my pointer, around here we got a fantastic reduction, and we plateaued. We absolutely plateaued. Now, the staff weren't doing anything different. The staff were still working really hard. The staff were still focusing on reducing catheter-associated urinary tract infections, but something wasn't happening. And it's going back to what everyone has been saying today, that in order to achieve this reduction, we have to work as a whole economy. And we can't call it a whole health economy. It's health, it's social care, it's everything. A lot of work is going on within our community settings. A lot of our population are now living at home and being cared for at home. And the only way we're going to do it is working together. And you can see where we've plateaued here. And like I said, at this stage here was when we started to implement, as a whole economy, the catheter passport. And as you can see, right down to the last quarter, there was one reported catheter-associated urinary tract infection. Just one in a 1 quarter period. Now, that is down to a lot of hard work for a lot of people. Like I said, East Kent Hospitals and Mason and Tunbridge Wells, and Dr. Sarah Mumford will tell you in a minute about, at the same time, they also implemented Houdini, which is an assessment tool for removal of catheters. Lots of other work went on behind the scenes. But interestingly, I was asked when I put this presentation together whether or not we had reduced the number of catheters we had in use. Sadly, I hadn't looked at that until that point, so thank you very much for challenging me on that. But when I looked, over this same 4-year period, the amount of long-term catheterized patients we had increased. So this reduction has come about purely by better care for the patients, not about reduction of catheters and long-term catheters. Now, there obviously is a different piece of work to be done about long-term catheterization, and like I said, I think in the acute sector we have different challenges with our short-term catheters than we do in our long-term catheterized patients, but it just goes to show that you can make a significant difference if you get everyone involved and make the patient the centre of it. And as I was saying this morning, listen to your patients and listen to them and what they're telling you. It can only work as part of a multimodal campaign. It can't happen in isolation at all. Like I said, the reductions were seen predominantly as part of the whole healthcare economy. Reductions, as you saw, were very gradual, but they are very effective. But again, I've been challenged. I've had people throw back to me saying, but do the passports actually stop healthcare staff from interacting and taking initiative? Well, they might. But for us, it seems to have worked. Now, again, as an organisation, what's interesting is that we are a little bit behind the times, and we are now moving to electronic recording. And we are now finding it a bit more challenging again to get information and data and central surveillance. So it's quite lucky that I was able to pull this data together now, because things are changing, and what I'm going to be getting the next few months won't be comparable to previous data. But we were able to show that there was absolute clear evidence of a reduction. I cannot say it was individually down to the catheter passports. It was part of a whole health economy, and like I said, the Acute Trust and Dr. Sarah Mumford will be talking about what happened in Mason and Tunbridge Wells, East Kent Hospitals, Medway and Darren Valley, all participated. And as we've talked today a lot about GPs, we had GPs sitting on the group, and it was the GPs were very honest. And they gave us a bit of a reality check, and we're able to say, we won't do that. We won't do that. But someone else might do. And by then telling us what we could and couldn't do, challenged us all to bring up something different, but gave us something that worked. The last question I put up here is, Can we do similar for non-catheterised patients? Well, I've just sat in a session before this about the leaflet for non-catheterised patients and people with urinary tract infections. But interestingly, while it's an information leaflet, should we be putting something together like this for people that have recurrent urinary tract infections that may be going to different GPs, to different people to be getting their treatment, and challenge that for the future?